So welcome to our ACE Leadership Collaborative. This is, and we are inviting the leadership of facilities. Natasha, I know you're participating in a couple of other our programs that we're doing that are targeting different roles within the facility, but this is for you guys, for leadership. So this is your very first learning session for the Leadership Learning Collaborative. And just as a reminder, we are collaborating with the Department of Health. This is a long-term care learning collaborative to strengthen frontline staff retention. And you're going to hear in just a moment from David, and the foundation is really around leadership and high performance. It is funded through the American Rescue Plan Act of 21. It's under the Nursing Home and Long-Term Care Facility Strike Team and Infrastructure Project. So Constellation Quality Health and, of course, South Carolina Department of Health are in collaboration to bring you this program. So if you were not on the kickoff call, we kind of did our introductions back in April when we kicked things off. But my name is Beth Hersher. I am the program manager for the ACE Leadership Collaborative. I have been with Constellation Quality Health for several years, working with nursing home task under our QIO program. Constellation Quality Health does serve as South Carolina Quality Improvement Organization. You just heard from Ann Louise. She is also with Constellation Quality Health as a QI specialist, and she's also a nurse educator. So Ann Louise and I will be helping David and supporting David through David Farrell, who you're going to get to know very well through this Leadership Learning Collaborative series. And he's a consultant for us and a subject matter expert. And I'm going to pause and just let David and Ann Louise say hello in a few words before we get started.
Sure, Ann Louise.
Sure. Again, Ann Louise Moran. I'm just happy to see you all. And for those who are nurses, just wanted to wish everybody a happy Nurses Week and enjoy the learning session. David?
Yes, happy Nurses Week, and glad you're here. Thank you for taking the time today.
Thank you, David. So before I turn it over to David, this collaborative series, we did kick things off in April. We're going to be hosting 60-minute learning sessions like what you're going to hear today, the second Wednesday of every month. And then the fourth Wednesday of every month, we'll be back together with you again to do a more informal coaching session, if you will. You'll be hearing from David on both the learning session and also the coaching sessions. Our goal is to learn how to strengthen frontline staff retention. And I think we mentioned this earlier, you've been registered for the entire series, so we'll be sending reminders for you along the way as we journey through the collaborative. Following today, you'll get this screenshot of this document. It has the dates for each of the learning sessions and the coaching sessions and the time. It's always going to be at 1 p.m. Eastern. So we are delighted that you are with us today. We want this to be active. We want you to participate. We just gave you a little task. If you have joined us late, we're asking for you to type into chat the name of your facility and your name, and then maybe what you did or what you are doing to celebrate National Nurses Week. David is a long-term care administrator, and he is also an author of 2 leadership books that are in the mail to you as we speak. You should be getting them within the next week or 2. And I share that with you because David will be tapping into some of the chapters of the leadership books around discovery and implementation. He'll share that with you on each learning session. But we want this to be also, he's written a wonderful journal on, I believe it's the Blue Book, David. You can shake yes or no. I think it is the Blue Book, and we've given you a note in your package that you'll be getting. It's a wonderful chapters to read. It's his journal of being an administrator and doing some of the things that we'll be sharing with each of you. So be looking for that. And with that, I am going to turn it over to David so he can get into the objectives for today and our content. David?
Sure. Thanks for joining, everybody, and hello. My name's Dave Farrell, and my goals today are to share with you just some really fascinating work that we did in California. In California. I'm in California, that we did in South Carolina, where we studied the best performing nursing homes from a staffing and a COVID perspective. I also did this in Alameda County, California, and Missouri, Louisiana. Nothing excites me more than talking about nursing homes that beat the odds and didn't have the devastating outbreaks and devastation of COVID that other nursing homes experienced. And that's what we're going to cover today. So if you recall, in phase one, we crunched all the numbers with the QIO and DHEC to identify 8 specific nursing homes in South Carolina that beat the odds. They had the COVID data that was outstanding. They had high star ratings. They had high staffing within those star ratings. So we came to South Carolina from multiple parts of the country, hopped in a couple cars and started driving all over South Carolina to visit with these leadership teams, see their organizations, and discover what they did. So what was it that they did differently? I mean, I was dying to know, because in my work here in Alameda County, I've been primarily only focusing in on the nursing homes that had the worst outbreaks. We had an outbreak team, and we were rushing into nursing homes with 50 cases, 40 hospitalizations, big nursing homes with terrible outcomes. But I knew in my heart there were facilities that were doing much better, and we needed to know how and why they were doing better than others. Was it that they had specific advantages and resources that other nursing homes didn't? Was it their physical structure? Did they have all private rooms? Was it something about the layout that gave them an advantage? Or had it to do with the acuity and age of their residents? Was it just who they were serving? Or the burning question could be, were they just lucky? Now, after all, as you know, COVID was like nothing we had ever dealt with before. The fact that it was airborne and so highly infectious. The fact that an individual could have the virus and that virus could linger in their body for 14 days before you'd see a positive test or a symptom. 14 days. And then when COVID came out or didn't come out in an asymptomatic case, the infectious period lasted 10 days. This is unprecedented with viruses in healthcare settings. And what made it so challenging, of course, on top of all of that, is that half of those positive cases that were highly infectious didn't know they had it, and no one else knew either. As you know, when someone has norovirus, you know it right away. When someone has the flu, you know it right away. When someone has COVID, you don't always know it. And then finally, as you know, especially in early 2020, just getting a test was a huge hassle, and you were lucky to get the test result back in 5 days or less. That made cohorting extremely dangerous. Next slide. Throughout this whole pandemic, new cases, spiking cases, high positivity rates in the general community went side by side with outbreaks in nursing homes. Now, this is a very broad view of the whole United States, but you see how those lines are just right next to one another. They're right next to one another. But there are exceptions. And we're here to talk about the exceptions, the outliers. Next slide. Early in the pandemic in 2020, it was so easy to study nursing homes. After all, so much information about nursing homes is in the public domain. And then when CMS required nursing homes to start inputting their COVID data every week, beginning on May 24th, 2020, of course, researchers took that data, cross-referenced it with other data that we knew related to nursing homes and began to identify these key variables that were associated with the biggest outbreaks in 2020. And they identified large facilities who took care of more residents, with more residents having behavioral health or dementia issues. For-profit ownership was closely tied to bigger outbreaks. If the facility hadn't gone through fit testing, or if they were serving a minority population located in a low-income zip code with a low star rating and a low star rating for RN hours and total hours, if they hadn't had an infection preventionist on staff, and if historically they got deficiencies on infection control, these were all important variables strongly associated with big outbreaks and high mortality in 2020. But of course, the pandemic went on. And by 2022, you can go to the next slide. By March of 2022, the researchers crunched all the numbers again, because a lot more facilities after 2020 also had outbreaks. And they summarized once again that the larger the facility, the more vulnerable that facility is, because viruses always come in with the staff. It's the staff who brings in the norovirus. It's the staff who brings in the flu. It's the staff who brings in COVID. So the bigger the facility, the more foot traffic the facility has of unique staff members. That makes a lot of sense. They also identified that the higher the nurse staffing, especially higher RN staffing, was associated with fewer cases and deaths. And at the end of the day, by March 2022, the 5-star homes and the 1-star homes, it didn't matter. For-profit, not-for-profit, didn't matter. Citations in the past, clean record in the past, none of it mattered by 2022. Next slide. So in South Carolina, what did these outliers do that worked? What did they do to prevent and mitigate COVID outbreaks in South Carolina? Well, what was so fascinating is we went on site with our masks on, of course, because we were still in COVID at the time. But we went in, we sat down with their leadership team, and we had very structured interview questions, starting with COVID practices. But no matter what COVID practice question we began with, they answered with leadership answers. They immediately went to their leadership and their staff as the reason, not specific COVID practices. Of course, we got to those, but we found that to be just fascinating. And as we toured their facility and looked all around their campus, we noticed that we were working and interviewing hands-on, roll up your sleeves leaders, DONs and scrubs, administrators moving mattresses, pushing carts. I mean, these are working administrators and DONs. They're humble. They were humble and reserved, kind of a paradoxical blend of personal humility and professional will is what we saw with these people. They said they kept things at very high standards, but they really care about their staff. They kept meeting with the staff. They're very inclusive, very transparent, felt like they were in partnership with the staff throughout the pandemic. But most of all, they created the conditions where the staff felt safe enough to keep coming back to work. Next slide. They were prescient. They saw it coming. I mean, they knew and read the news about New York and Boston and some of the guidelines that were being imposed on nursing homes there, and they knew it would eventually come to South Carolina. So they would start implementing stricter guidance before DHEC did, and they would get ahead of it. And they told us, and once we put it in place, whatever the infection control guidance was, whether it was masking, screening, testing, they said, whatever we put in place, we did it to the fullest. It was at the highest fidelity. If we walked to a nursing station and saw a CNA with their nose outside of their mask, we would, in a nice way, say, hey, Dr. Nose is in the room. There's a nose. Whose nose is it? Just to kind of get everybody back to where they need to be. And finally, they told us, as the CDC and the state started to pull back some of their infection control guidance and restrictions, they were like, nah, we're going to keep it in place for a while. And they would, and some still are. Next slide. And this is exactly what Dr. Nimily Stone from the CDC said in April 2021. She said at the time, what I've noticed is that the nursing homes that are the first to implement COVID restrictions and interventions, those are the ones that have kept it out or minimized the outbreak. What did they do specifically to prevent and mitigate? These were the themes. The screening at the door. I've been to, gosh, over 50 nursing homes over the course of the pandemic, probably more like 60. I've been screened 50 or 60 different times. You can recognize at the door whether you're screened or not so screened. It's easy to see. And when we went to these 8 facilities, we were very actively screened. Active means someone is behind a partition, asking you the questions, looking you in the eyes, taking your temperature, writing down your answers, very active. Passive, the opposite is, oh yeah, just take your own temperature, fill out the form, throw it over there, come on in. So that's not what we experienced in these facilities. When we asked them about PPE and being short on PPE, they said, no, we were never short on PPE. We said, why? Other facilities were. They said, well, number one, we stocked up early. We were ahead of it. As soon as we heard this going on in China, we started to purchase. But then they just did whatever it took to get PPE. They, whatever the cost. I remember one administrator telling us that he met some shady character in the back of a liquor store and bought 2 boxes of N95 masks for cash. They would say they were doing whatever it took to get the PPE, and their staff never ran short. As I mentioned, they minimized the foot traffic. They had very active and involved medical directors who showed up on site every day, not just telehealth, but showing up. They weren't marketing themselves as COVID competent to the hospitals. They had no intention of directly admitting new COVID positive residents to try to capitalize and have a pretty healthy bottom line by doing so. No, they weren't interested in that at all. Remember, these were humble leaders. They were humble enough to know that COVID is deadly. And so they were not interested in this being a marketing opportunity. And believe you me, all the hospitals wanted them to take COVID positive because they were 5-star facilities. They had great reputations. They had good, strong infection control. They weren't having big outbreaks. So of course the hospitals were looking to them. And they were like, no, thank you. We're taking care of our own. They did have outbreaks at these 8 facilities. They were very small, quickly contained. And then whenever they had an outbreak, the leaders would have a quality improvement debrief with each nursing neighborhood or station and talk it through. What happened? How did it get in? What could we do better next time? What are we going to do better next time? So they just treated every outbreak as an opportunity to get better before the next one. Related to communication, oh my God, all the AFLs coming out from DHEC, all the guidance, hundreds of pages of guidance that we had to stay on top of. How did the Outliers dissect the guidance, update their policies and procedures, and get it out to their staff as fast as possible? Well, one thing we learned from these 8 outliers is they all had huddles. The leadership team huddled with their staff daily before the pandemic began, and they kept those huddles going with their staff daily after the pandemic began, just with some more distancing. And instead of being in the conference room, they were huddling in the big dining room that was shut down. So they would meet with the staff daily. They would ask the staff what you're worried about, what concerns you. They would admit to the staff when they didn't know something, and they'd say, "We'll go find out." But they kept the staff informed, and the staff felt safe because they told them this is probably the safest place that you can be. They also used group text messaging and Facebook page video boards. One facility used a big binder at each nursing station that clearly showed the COVID status for each resident within that neighborhood. And most importantly, they all said we didn't ignore the night shift. We didn't ignore the night shift's concerns. We didn't ignore the fact that they would be alone in the red zone at night. I remember the DON at NHC Sumter worked the night shift in the red zone the first couple nights just to make sure. I mean, they basically said we're obsessed with the night shift because we feel it's a vulnerable area. And the research shows that they were absolutely right. Next slide. It was also funny how they discussed how they were able to trigger the right behaviors on and off the job. After all, what staff did outside the work strongly impact whether they would get infected and bring the virus into the facility. Next slide. We interviewed the DON from Pruitt Health Barnwell, and I remember she said, "I told my staff, don't mess up at Walmart." And she was quite a character. She said that the residents and families even would comment to her about how the staff were acting outside in the community of Barnwell. They noticed them masking, social distancing, but these leaders talked to their staff about making good choices about who you socialize with, which social events you go to, and how to behave when you get there. And their message to the staff was, hey, what we do in our personal lives is going to affect the residents' safety. It's going to potentially impact whether our residents live or die. So we're accountable. And they emphasized it over and over again. In terms of the vaccine, they had incredible high vaccination and booster rates. How did they do it in South Carolina and in counties with very low uptake of the vaccination and the booster shots? How'd they do it? Well, the leaders went first. Some of them were hesitant. Remember, the vaccine was released on December 30th, 2020. We didn't even know if it would work, right? These were scary times. But in these 8 homes, the leaders went first. They took pictures of the medical director administering the dose to the administrator and the DON. They took pictures of it. They posted it on social media. They made it a celebration, basically. I mean, finally, a vaccine. We can get through this. But still, there were many hesitant staff members, many hesitant residents. So their medical director would get involved, have meetings with the hesitant ones, one-on-one discussions with family members who didn't want their loved one to get the shot. One administrator told me that a CNA came to him and said, "My mother said I shouldn't get the shot. What do you think I should do?" And I just thought that that was pretty cool that, you know, that you had that level of trust, that he would come and ask you a question like that. And of course, that CNA did eventually get the shot as well. They made it fun. They gave them rewards. Some gave raises, some gave bonus cards, some gave gift cards, whatever it took. And some even mandated the vaccine before the federal government did. And then ongoing, they just use multiple strategies because remember, that vaccine was 2 doses, and then before you knew it, another booster, another booster, another booster. It never stopped. So this was an ongoing quality improvement project for sure. And these 8 high achievers use multiple strategies. Number one, they asked the hospitals, please give them the shot before you send them to us. They became a vaccine provider with the state of South Carolina, had the vaccine delivered directly to them, didn't have to go through the pharmacy. They designated frontline staff champions to speak to the hesitant residents and family members and coworkers. They publicly posted vaccine and booster coverage goals that you see in the lobby and in the break room. They publicized their goals. We want 95% of the residents boosted, 95% of the staff. We won't let up until we achieve our goals. They also sometimes had to give the residents inexpensive rewards, like, John, will you please get the shot? What if we got you your favorite dinner from Ham's Barbecue? What do you say? All right, great. Let's go get John's dinner and then we'll give him a shot, you know, whatever it took. They also armed the vaccinated CNAs with good talking points to share with the unvaccinated CNAs. And whenever the IP or the DSD was doing the COVID test and testing someone who was unvaccinated, they used that time to make another plug to get the vaccine. And finally, the last bullet, they'd often get questions from the staff and residents, is this going to be the last dose? And their answer was always no, you'll likely need another dose. Next slide. And they were spot on. Their efforts worked, right? I mean, the research came later. They didn't know they would be so successful, but the research came later. Clearly, the vaccine made a difference. Next slide. And then the booster made an enormous difference with the Omicron surge. The case rate amongst residents with an additional primary or booster dose remained 10 times lower than those who did not get it. Next slide. What did they do and didn't do that worked when it came to COVID testing and cohorting? Let's dive into that. So in August 2020, the Department of Health and Human Services began shipping Cadell antigen testing devices and test kits to every nursing home in the country. Remember that? The Cadell box arriving at your door? Now the Outliers got that box, ripped open the box, and got going right away. You know, they were so frustrated with PCR testing, the unpredictability of when you would get your result, the slow test results, the long wait for the test results. So when they got these devices, they were early adopters. Now, these devices had their flaws, and you definitely needed to devote 2 nurses to this work. But hey, we could get results in 15 minutes or less if we just set this system up. Many nursing homes, as you can see, just blew it off. They were just like, we'll just stay with the lab-based testing. Yeah, it sucks, but what can you do? At least it's accurate. And then we were, of course, still facing dangerously long waits to get those results. So yeah, the results were accurate. But if you tested someone who was positive and you didn't get the result back till 5 days later, and that positive person got to walk around your facility for 5 days, that didn't help you very much. Next slide. So again, these folks knew that PCR testing and the slow test results were killing them. So they were the earliest adopters of point-of-care rapid antigen testing. And by November and December, the federal government was sending nursing homes all over the country Abbott Binax Now test kits that we still use today. So we didn't have to use the Cadell by November. We were all on the Abbott Binax Now, those who had adopted it. But still some facilities stuck to PCR testing and the lab-based testing. But they were aggressive with the COVID antigen testing. They were using it for diagnostic screening testing. They were testing people outside of the facility before they could work. If a staff member called in and said, I'm a little sick, they would drive to the person's home and test them there. They truly understood the risks of slow PCR testing, and they truly valued the frequency and timeliness of the point of care antigen testing. Next slide. And a team of Harvard researchers pointed this out in 2020. You can see it's a very busy slide, but the title of the slide is Speed Matters Much More Than Sensitivity. So speed of the test matters much more than the sensitivity of the test. And then if you look over to the far left-hand side, what you see here is what they've done is they've matched up a simulated study of a nursing home using PCR testing or rapid antigen testing at the beginning of an outbreak. At the top, you see PCR tests with 100% sensitivity, meaning that 100% accurate detecting a positive case, but a 48-hour turnaround time to get the results. Below that, you see on the side, rapid AG test, only an 80% sensitivity or accuracy, but you get a 15-minute turnaround and a 30-minute confirmation, meaning you just repeat the test and see the results again. Of course, 80% sensitivity is not accurate. The Abbott Binax Now test kit is 96.7% accurate. But without a doubt, PCR testing is a little more accurate than rapid antigen testing. Okay, so you got your context. Now look, keep with me on the left. So first round of testing on the PCR side and nursing home 1, they catch 5 positive cases that they've swabbed. See that, the 5 dark figures? And over here at the bottom, they also had 5 positive cases, the 5 dark ones. Now, because the PCR test of those 5 positives, they don't know they're positives. Yes, they swabbed them that day. They sent the specimens to the lab. But over 2 days, as you can see, the 5 positive cases that were swabbed 2 days ago continue to linger and work and do their jobs. Finally, they get the results, as you see on day 3. And the arrow points up that they quickly isolate the 5 positives because they finally caught them 2 days later. But in the red, you see all the other staff and residents that now have to be quarantined because those 5 positives lingered around for 2 days. And amongst the 5, all those people quarantined, 2 are positive. Now come with me back down to the bottom, to the AG testing. They also had 5, as you can see, They got the results in 15 minutes, but they missed one, right? An 80% positive sensitivity. They missed one, but they isolated 4 of the 5 right away. You can see at the bottom. One was able to linger for 2 additional days. When they came back and did another rapid test, they found that one that was lingering. They isolated that person, and that person over 2 days looks like they exposed 5 additional people and 1 got the virus. By day 5 now, with PCR testing, there are 5 additional positive cases now lingering in the facility. And with AG testing, there's 1. So the outcome to the far right, you can see here, new infections with 100% sensitivity using PCR testing every 3 days nets 8 additional positives and a whole bunch who have to be quarantined. New infections with just 80% sensitivity, but a 15-minute turnaround time, just 2 positives and 4 people under quarantine. Again, the researchers from Harvard just make it crystal clear. Rapid antigen testing rules in congregate settings like nursing homes. The key is do it frequently. Do it 2 to 3 times a week. But once a week PCR testing has been, with a 48-hour turnaround time for nursing homes, has pretty much been a disaster. Next slide. What did they do that worked related to staffing and staff assignments? Well, they had consistent assignment before the pandemic began. Of course, everybody has a choice. You can have rotating staff assignment over weeks or months, or you can have consistent assignment where people are assigned to the same group, the same neighborhood for the whole time that they work there. In the outlier homes, they were using consistent assignment, and they pointed to consistent assignment as one of the keys as to why they may have done better than others. Because with consistent assignment, of course, CNAs and LVNs get to know the residents deeply well. And COVID symptoms in very old people can show up in strange and unique ways. A fall with someone who never falls before, diarrhea, just all sorts of quirky ways COVID shows up. So when you have consistent assignment and the CNAs so deeply know the residents, they're going to pick up on these subtle clues that could be COVID. Whereas other nursing homes with rotating assignments may be less inclined to pick up those subtle changes in the residents. When they do pick up those subtle changes, they treated them as positive, and they had a COVID order set that they would implement. Put them on oxygen, breathing treatments, head of the bed at 90 degrees, and they were ready to send them out to the hospital quick. The hospital in 2020 and 2021 was the only place a resident with symptoms could be saved, and they didn't hesitate. You had to get them there early. ER doctors told them, don't send us a resident who's already on 15 liters of oxygen. By then, it's too late. Send them when they're on 3. Send them when their O2 drops from 93 to 91, not from 91 to 97%. So this is what they did. They were fast and aggressive with getting people to the hospital once they saw symptoms. Next slide. And of course, the research around the consistent assignment being advantageous over rotating a staff assignment has been around for years. And there's really not a single research study specific to nursing homes that outlines the value of rotating staff assignments. Next slide. What did they do that worked that helped minimize the spread of the disease? Well, they knew early on that it was this disease was being spread through the air. It was airborne. And of course, by October of 2020, we all knew that it was airborne. So while some nursing homes were hiring extra housekeepers to wipe down doorknobs, the Outliers were investing in cleaning the air. Next slide. So what did they do? They purchased and used air purifiers, air scrubbers, foggers, and they got accredited HVAC system workers to look at their airflow throughout their facility. Next slide. They also jerry-rigged negative pressure rooms. Of course, just like your nursing home, these nursing homes didn't have negative pressure rooms, but there were things that they could do to kind of jerry-rig it. And here were some of the things that they would do when they have a positive resident. Number one, they would put that positive resident in a private room if they had one. They would close the door, and then they would quickly identify which of the two fans in the ceiling was extracting the air and which fan was blowing air in. They would seal off the fan that was extracting air out of the room. They didn't want dirty air being circulated throughout their facility, so they would shut that one vent. In addition, they'd take an air purifier and put it in the positive resident's room when they were in isolation, preferably at the foot of the resident's bed, not in a corner. And in addition, if they could, they would open a window and they would take a small fan and turn it around so that it was exhausting the dirty air out of the positive resident's room. Next slide. And then once they did all that, they would see which way the wind is blowing out of that positive resident's room. Here she takes a little piece of toilet paper. What she's hoping for is that the wind from the hallway is blowing into, and that paper's being sucked under the COVID positive resident's room. And indeed, with all those jerry rigs that she did, she was able to achieve that. In terms of the HVAC system, well, there was plenty to do there as well, making sure that the outdoor air damper was open till its fullest extent to get the most fresh air in, adjusting the system so it wasn't running automatically but continuously, reducing or eliminating any type of re-air circulation in the system, and then, of course, upgrading the filter with a MERV 14 or higher filter to clean the air with the best filter available. Not everybody could do this. Not everybody had a high-tech HVAC system. Some facilities here in California have zero airflow in their facilities, but they did whatever they could once they recognized this thing is in the air. And once again, they didn't know if it was going to work. Research came out later that proved it worked. I remember the administrator at NHC Sumter walking around saying like, oh man, she said, I spent so much money on the air purifiers and scrubbers, thousands of dollars. And she said to me, I don't know if it worked. And Beth and I said, we think it worked. We're here interviewing you. Obviously it worked. Next slide. And then finally, related to staff stability. As you know, when staff leave in droves at the beginning of an outbreak because they're scared or there's no PPE, that outbreak turns into a disaster. And many, many nursing homes experienced just that. We had a nursing home here in LA the day after the outbreak. Only one CNA came to work. We had to evacuate the nursing home. Pretty bad, right? really traumatic for the residents, but it also spoke to the lack of leadership, right, at that nursing home at the time. But most nursing homes experienced losses and were still struggling to fill those open positions. But the outliers generally kept their staff. Most of them said we didn't use registry. They maybe lost a few people, but they kept most of their staff. And so we were very inquisitive. How did you do that? How did you do that in the face of all the pressures on the staff, all the conditions that they were facing? Well, they really focused on keeping the people that they had. And they created the conditions for their staff to want to stay. Like I said earlier, they talked constantly to their staff about their facility being a safe place because everybody's vaccinated here, everybody's tested here, everybody's wearing N95s here. You know, you couldn't be in a more safe work setting. And it was true. But they reminded their staff of that constantly to get them to come back to work. In addition, related to consistency, the leaders we met, they all basically said that they were obsessive and compulsive about infection control. So they had very high expectations, but they are also good at educating their staff around their expectations and why they were so OCD. They held people accountable, but they held them accountable in a friendly way, in a professional way. So they didn't scold people. They didn't lose people after scolding them. Somehow they kept them, and they kept them to a very high degree of infection control standards. In terms of communication, they would meet one-on-one with staff who were struggling. They always were having huddles and group meetings. They worked alongside the staff. You know, all the DONs we met said during our first outbreak, I was the charge nurse in the red zone. You know, I'm taking the lead. These are the type of the leaders that we met. In terms of valuing staff, they were flexible with their schedules, super supportive of their families, caring about the safety of their families, and showing great respect for every job. And then finally, under trust, the staff could trust them because they knew their leaders were honest and humble and transparent. And that essentially created this mutual commitment to one another. They knew their bosses would do whatever it took. They were working alongside them. And then at the same time, they were constantly rewarding and incentivizing and appreciating their staff. Let's hear from one of the ones we interviewed.
Treat them as human beings.
Yeah, we love them.
We care for them. You know, it's not they're not robots. They're not, it's not about a piece of paper. You know, it's about what's in here. We individualize them, you know, what's going on in their life.
You know, and I think I said this before that, you know, I tell every one of my CNAs and my nurses is, you know, I treat them like a garden. They're the beautiful flowers,
Right.
you know, and you have to, the grass is greener where you water it. And I say that all the time. And me and Marianne water our garden.
Right.
And we love them. And
Right.
they know their family. When we
Right.
walk up and down the halls, we sincerely ask how you're doing.
Right.
When I ask how you're doing, I don't mean how you're doing right now in this moment at work. I mean, how are you doing? And they know that that's what we mean. You know,
That's right.
their family.
I round on the units. My administrator rounds, you know, our nurse managers are constantly out there all day. And so we do get to talk to our folks and ask them how they're doing, or ask them about Johnny Sue, and that's just, of course, a made up name, but ask them about their children or whatever the case may be. How's dad doing? And, you know, how's your mother this week? Is she any better? You know, and that really helps our staff feel like that they can be open and honest with us.
They clearly did more than the staff expected. We heard examples of gifts, sweaters, sweatshirts, prepackaged frozen meals they could take home to their family. They were handing out toilet paper and paper towels to the staff when those were in short supply. They called them care packages, and they would be a box full of the staples with bread and cereal. And essentially, they had this ulterior motive that they were also trying to keep their staff from wandering around and shopping in a grocery store, which could lead to a virus back at the facility. But these were really important gestures to the staff and tangible stuff that they could take home to their families. And in addition, most of them didn't want their staff to use public transportation in the height of it. So they would rent cars or get Uber rides for them. Some would even stay in hotel rooms. One facility had a whole bunch of empty assisted living units, and they let the staff stay there if they were concerned about infecting their family. Next slide.
David, and for the sake of time, do you want me to go to that final, it's a little bit longer, that final video that kind of has a compilation of everyone that we interviewed?
Yeah, let me just finish this one part
Okay.
here. This is really important, this piece right here. Making sure that staff could pay the rent. After all, we employ 50% of our staff are low-wage earners. 50% have English as their second language. So if PDL and sick pay to cover isolation and quarantine time wasn't available, and it wasn't explained to the staff that we have your back, if you got exposed, we have your back. If you have to quarantine for 14 days, don't worry, we'll pay you while you're off. This was really important. If we expected the frontline staff to tell us the truth about who they were with us last weekend and how they may have been exposed, you had to give them a safety net, or they were not going to tell us what happened. Next slide. So this really happened. This is the Swiss cheese hypothesis, if you will, of a COVID outbreak. In this one particular facility in Alameda County that I studied, they offered no quarantine or isolation pay to their staff. If you either had the PDL or you didn't, they weren't worried about it. At this facility, the staff screened themselves at the door. So a CNA that was fairly new came in, had a cough. She self-screened at the door, took her temperature that was a little elevated, turned in the form, clocked in. No one even looked at the screening form. She worked from 3 to 11 with 15 residents, coughing a little bit, but worried about paying the rent because she cannot afford to be off. But she could have, but she doesn't know that the facility didn't offer. The facility didn't offer it. Her symptoms worsened overnight. Calls off the next day. The facility didn't even ask why she's calling off. She goes and gets tested at a county clinic, tests positive, calls the nursing home, tell them she's positive for COVID. So they start testing, and in the first round of testing, 8 residents out of the 15 in her group test positive. All of this could have been avoided if that CNA had simply been honest, been appropriately screened, and educated that the facility had their back and they would be paid if they stayed home. Next slide. Oh, there's the line. Yep. Okay, we're wrapping up here. So yeah, let's go to that summary. We have a really nice summary video so that you can really get to know some of the great leaders that we met. Go ahead.
same things, you know, that will always make any facility successful. It's not the building or the walls or the paint, it's consistency. It's core partners that's going to be here with you through thick and thin, and it's making them feel like we are a work family.
I feel like as a team, we've always worked really hard together. You know, we've had the same values, we've had that same mission statement, and we've really stuck to that. And so when hard times came along, like COVID, we had that foundation to rely on.
I think a lot of the big things are communication, teamwork, having, you know, policies and procedures in place and being organized.
If we do communicate with each other and we talk about the problems that we have and we figure out together how to fix them.
And really supporting one another, caring for one another, and, you know, being open and honest and being able to be vulnerable and say that I need help with, you know, X, Y, Z, and then receiving that help.
All my workers have my phone number, and they have mine, and they usually reach out to me all times of day, you know, if they need something. And I try to tell them that that I'm the director of nursing, and my job is 24/7. It doesn't just end when I leave the building, so they're able to contact me at any time of day if they need to.
3, 4, 5 years ago, if somebody was late as a leader, you know, we had a policy, we checked a little box, kept up with how many times that happened, and you'd have a conversation. Well, it was a different conversation through the pandemic, and it continues to be that way. Before, it might have been very driven from a leader to an associate, and now it is driven from, tell me what's going on.
Our brains were fried many days, and we needed all the brain power we could get from one another to come up with some creative ideas. And it didn't need to come from a top-down perspective. It needed to really come from the people that were working it every day.
We don't ask them to do anything that we can't do. They see us working beside them. If they're swamped, we're out there. And I just think that whole teamwork approach just made it a better place to work during this time. You were never on your own.
You know, you would go to their office and they're not in there because they're out on the floor. They're out making sure the staff's okay, the residents are okay. They're here on Saturdays. They're here at night during COVID. So I feel like the biggest thing is your top, your leadership. So if we see them doing it, we want to do it too.
So that was a compilation of what David has been talking about with the leaderships, those 8 facilities, and when we went to see them. And I think really this picture that how they work together, David, if you would agree, how they work together during the pandemic certainly lays our foundation for what we're going to be doing throughout this series with high performance and high leadership, and just what an impact that has on all staff, frontline staff, and really everyone in the facility. Just a few announcements. Ann Louise and I will be giving you throughout these for the next learning session. We'll be giving an update on our frontline supervisor support training series. A lot of you have identified nurses to go through that web-based training learning environment. Ann Louise is working with them on that. I'm working with the NACA CNA preceptor turnover management. Many of you have CNAs that are going through that training. So we'll be giving you updates as we go through the learning sessions. So we just want to let you know that's coming each each learning session. I will send out after this webinar. We are asking that you share data with us. As I said in the beginning, we really want this to be a teaching and a learning moment, just to help us adopt new ideas of what's working, maybe what's not working. So I will send that link out. It's a very short form that you'll fill out to give us direct care staff turnover rate, new hire retention rate, and then your unplanned monthly call outs. These sessions build upon each other. So with this real-time self-report data that we're getting will help David as he puts together the next sessions to kind of really peel the onion back on staff stability and these areas that that you're tracking and measuring. Again, what I just said, you'll be hearing about financial practices, care practices, workplace practices. It's with what we're calling a bundle of interventions, and that's really going to be the focus and highlight for Learning Session 2. All right, and we just want to leave you with, this whole series is if you can't change something big, change something small. As Don Berwick, former president of IHI, a quality improvement champion. And that's what we're going to be, David is going to really be diving in going forward, is those small things that make a huge difference. So we thank you so much for today being with us, and you'll be getting a follow-up email, and we will see you guys May 22nd for our coaching session. Thanks, everybody.